First symposium of the day explores the field of toxicology. May I now invite Dr. Ravi Jayawardena and Dr. Prasad Sirivardhana to chair the session.
Welcome to the Symposium of Toxins and Bites. First speaker is Prof. Anjana Silla, the Chair, Professor Parasitology, Faculty of Medicine and Allied Sciences, Rajaram University of Sri Lanka. Topic is controversies in snakebite management, navigating the gray areas.
A very good morning to all of you, and thank you very much, Chairperson, for the nice introduction. And I thank Sri Lanka College of Internal Medicine for inviting me for this talk. And I'll be talking about controversies in snakebite management. And there are a lot of gray areas, and I would be discussing how we can use the existing evidence as well as our narrow but yet what available understanding of the pathophysiology in navigating through these gray areas. So I declare I have no conflicts of interests. So a snake bite is a serious public health concern, especially in the tropics. And Asia bears about like 2/3 of the global snake bite burden. And Sri Lanka is a snake bite hotspot. So the community-based estimates suggest about like 400 snake bites per 100,000 population per year, which is one of the highest in the world. And especially certain parts of the country like North Central Province, these numbers are even higher. And when it comes to envenomings, in Sri Lanka, it's about like 150 envenomings per 100,000 population per year. It's again a very high number, and certain parts like North Central Province, the numbers are about 3 times high. And comparatively, death rates are actually low in Sri Lanka in snake envenoming, which is a very good thing. And compared to most of the other developing countries where snake bite is a problem, death rates are quite low. I think mostly because of the excellent medical service provided throughout the country for snake bite patients, despite having issues with treatment options. So the specific treatment options available for snake bite in the world is antivenoms. So antivenoms are about like a very old treatment, about like 130 years back. The first antivenoms were developed. Since then, the fundamentals of the production of antivenom remain the same, and the production procedures have greatly improved, but there are still problems related to antivenom, especially the evidence and the the understanding of the limitations of antivenom treatment. So one of the problems that snake envenoming suffers for a long duration is that most of the practices lacks evidence based or not backed by evidences, and rather due to long lasting certain opinions on snake bite management, they themselves have led to controversies in snake bite management. So just to start this, let's focus on a Russell's viper bite patient. So 38-year-old farmer bitten by Russell's viper, specimen confirmed 1, was admitted to Anuradhapura 1.5 hours after the bite. And on admission, there was only mild swelling and pain, no clinical evidence of systemic envenoming, no bleeding manifestations, and as usual, whole blood protein test negative. So the patient was kept under observation, and 2 hours later, the patient started to vomit, and the repeat whole blood protein test was positive. And patient received 20 vials of Indian antivenom. And at the same time, the INR that was sent on admission came as 3.2. So clearly, the whole blood protein test missed coagulopathy on admission. And then 6 hours after the first antivenom dose, WBCT is still positive, and INR was 4.1 again, and no bleeding manifestation. So what are we going to do? So why the whole blood protein test missed coagulopathy at the beginning, and then now the 6 hours after the bite, patient is still having coagulopathy what are we going to do? Are we going to repeat antivenom? And another case of Indian grade 10 venoming. Patient presented at midnight, about bite occurred around midnight. Patient admitted 1.5 hours later, only having mild ptosis at that time. Patient was given antivenom, but then despite giving antivenom early, within about 2 hours of envenoming or the bite, patient continued to have progressive neuromuscular paralysis, resulting in respiratory paralysis. So what has happened here? Why did early antivenom not work in this patient? And what are we going to do with this patient? So first, quickly, let's discuss what are snake venoms. Snake venoms are cocktails of different pharmacologically active toxins. It's a mixture of toxins, not a single substance. Now this graph shows this is a HPLC of Russell's viper venom from Anuradhapura. Now you see there are several peaks in it, and these peaks are not individual toxins actually, they are toxin groups. So if you look at coagulopathy, these are the 2 peaks that are relevant for coagulopathy. And then for rhabdomyolysis, there's this peak. And then for neurotoxicity, these. And some of the peaks, we don't know whether they are relevant for humans, whether it's useful for the snake to catch mice and all that, we don't know. So it's a complex cocktail. And then these toxins are, they have pharmacokinetics and dynamics completely different. So it's not, it's not something like we are dealing with paracetamol poisoning where we are dealing with one substance, one pharmacologically active substance. It's a range of different substances that we don't know. So individually, now these toxins may have different pharmacokinetics, their absorption and elimination kinetics, they all may differ. And also each bite, they inject different amounts of venom into different tissue depths, and also their actions in tissues may be different. And also they have ontogenic variations. For example, the baby vipers, their venom is different to the adult vipers. Now these days you might encounter baby viper bites because this is just after their breeding season. So most of the patients don't develop neurotoxicity, they only develop mild coagulopathy. But later in the year when they grow bigger, you will see differences in the clinical picture. So my first point is snake venom is not a single bioactive substance, but a complex cocktail, and they have different PKs and PDs. So as clinical picture, when you see a patient, it's just a snapshot of dynamic events happening in the patient. So then what pathophysiological processes are involved in snake envenoming? So first thing is venom-induced consumption coagulopathy. That is the most important and commonest systemic effect of snake envenoming. Actually, there are 2 arms. One is the coagulopathy, the other one is vascular damage. They occur at the same time. So snake venoms have toxins that activate clotting cascades, specific toxins at different points so that the subsequent stream is activated. For example, Russell's viper venom has clotting factor 5 and 10 activators. This will activate the entire clotting cascade, then gradually consuming all the clotting factors and ultimately consuming fibrinogen, converting them into fibrin. And this fibrin will be then degraded by the fibrinolytic pathway, increasing D-dimer levels. At the same time, certain vascular toxins start making holes in the vasculature, leading to leak. So it's not only the coagulopathy, but also the vascular damage in combination leads to spontaneous bleeding. Now these are clotting factors and clotting parameters of 146 patients bitten by Russell's viper. So first 2 graphs show INR and APTT, and then the bottom one show fibrinogen factor 5 and factor 10. And in each of these graphs, the solid line indicates whatever the parameter we are testing, and the interrupted line shows venom levels in the blood at that moment of the patient. Now you see, immediately after giving antivenom, that is the interrupted line, quickly the venom levels in the blood drops in these patients. So that means after giving antivenom, there's no free venom in the blood. Antivenom, Indian antivenom, effectively binds with the venom. But the INR and APT, they are slow to respond. They take time to recover. There's no free venom in the blood, but the clotting activity takes time to respond. Why? The antivenom does not replenish clotting factors. Its antivenom does not contain clotting factors. It is the liver that actually involves in replenishing the clotting factors. It takes time. It takes usually about 2 to 3 days to fully replenish the clotting factors. And what it basically suggests is your action of antivenom is in the central compartment, not so basically what it can does in the central compartment, it does. And if you give antivenom early, you can prevent further consumption of clotting factors. If you are late to give antivenom, most of the clotting factors are already consumed. Now you have to wait longer for the liver to replenish the clotting factors. Neurotoxicity, mainly snake bite, leads to treatment-resistant neuromuscular paralysis, especially in grade 10 venomings. So the pathophysiology is again, presynaptic motor nerve terminals are structurally damaged by the grade neurotoxins. So this kind of structural damage will not be readily reversed by any treatment. What the treatment does is, it will only work in the central compartment, binding into the toxins, but neuromuscular junctions, antibodies, antivenoms can't reach. So whatever the toxins that are already gotten into motor nerve terminals, they will exert whatever the pathophysiological processes they started. And you can basically wait and see until the patient's motor nerve terminals are recovered. So there's the pathophysiology is irreversible. What we can do only is at the central compartment. And the other problem is the AKI, acute kidney injury. In the world, there's no specific direct toxin discovered that damages kidneys directly. So there's no direct toxin-mediated renal injury. Most likely, it should be something due to indirect mechanisms. So acute kidney injury, MAHA and thrombocytopenia appearing simultaneously in some patients. So they suggest thrombotic microangiopathy, but we do not understand how these pathophysiological mechanisms work. What we see is that it's more similar to hemolytic uremic syndrome than TTP, and that's why some people try using therapeutic plasma exchange. And also cardiovascular collapse or hypertension as well as rhabdomyolysis may aggravate this renal damage. So the second point is, most of the snake venom mediated pathophysiological insults narrow window of opportunity for interventions to prevent toxic effects. We have a very limited time to work at the central compartment to neutralize the toxins. And pathophysiology in especially renal insult, we do not understand. So the other issue is that there's always skepticism about Indian polyvalent antivenom, whether they work for Sri Lankan snakes. Throughout the last decade or so, we have done many studies. Now we are very clear that Indian polyvalent antivenom has sufficient antibodies to neutralize all Sri Lankan medically important snake venoms apart from hump nose vipers. Even Ceylon crate, Indian polyvalent antivenom have antibodies that are capable of neutralizing the neurotoxins. And also clinically also we have shown that Indian antivenom actually accelerates recovery from coagulopathy in Russell's viper bite patients. Again, how the antivenom basically binds with the toxins in the circulation, keep them inhaled in the circulation and promote elimination, while the liver replaces the clotting factors. And crate bites, what we have shown is that, again, crate bite patients, after giving antivenom, immediately the venom levels go down. So that means antivenoms do their job in the circulation, but the patient's neurotoxicity does not respond in that manner, because by the time the antivenom is given, already the toxins entered into the motor nerve terminals, they continue their pathophysiological processes. So there's a very narrow window of opportunity. So therefore, now in crate bites, there's efficacy. That means antivenom binds with the toxins in the circulation, but poor effectiveness, not due to bad antivenom, It's because of the nature of the pathophysiology and limitations of antibodies to reach to neuromuscular junctions. So, third point is Indian polyol antivenom is efficacious against Sri Lankan snake venoms and should be given as early as possible before the toxins reach to target sites. So we have to give as early as possible so that you can minimize the irreversible damage. So early first dose is always better than repeated late doses. Then the other problem is how we can reliably diagnose envenoming early. So one big problem we are having is that our patients come to the hospitals quite early. Even in rural areas like Anuradhapura, the median time from bite to hospital admission is about 40 minutes. But then median time from bite to antivenom is about 180 minutes. So that is because it takes a lot of time for us to fully convince that the patient is envenomed. Right? It's not a problem of our decision making, it's a problem of lack of reliable diagnostic tests. So one test that we often use is whole blood clotting test, 20-minute one, which is a very simple method, and you all must have done this test. So one of my PhD students who recently finished a PhD did study this test in great detail. So what she found was that the whole blood clotting test misses more than 60% of patients with mild coagulopathy on admission. So what happens is, when they develop severe coagulopathy later, several hours later, then the test is able to detect the coagulopathy. So essentially what the test forces us is to wait until the coagulopathy becomes severe enough for the test to detect, rather than detecting the patients earlier. So therefore, whenever INR is available in your places, you should use INR rather than using whole blood clotting test. So these are just figures. You see, sensitivity of detecting INR more than 1.5 is about 35.8 for whole blood clotting test, and INR more than 3 coagulopathy, it's double. So it detects severe coagulopathy better. And also, those presenting early, the test is poor. Those presenting late, test is doing better. So that means, again, the test keeps us waiting. So that's why we basically suggest in diagnosing and monitoring week, if the INR is available, use INR. And if INR is not available, rather than waiting for 6 hours, do a whole blood clotting test in 3 hours. And then there are other things like non-specific features that are usually most clinicians are basically looking at, and they seems to be really helpful. So we were conducting some studies on this. What we found was non-specific features like abdominal pain, vomiting, and headache are really indicative of subsequent development of envenoming. So we tested a diagnostic algorithm where when a patient presents with non-specific features, we consider the patient as envenomed, and those who are not having non-specific features then were guided by the whole blood clotting test results. So when we analyzed the sensitivity and specificity, it was really interesting. Whole blood clotting, these are only Russell Swiper bites. So the whole blood clotting test performance is it's alone 60%. And any non-specific symptoms alone, 72%. Once we combine these two, the sensitivity improves up to about like 88.2%. And then specificity also, keeping a specificity of about like 90%. So that means combining with non-specific features would really, guide detecting of envenoming. So one key thing to remember is that negative whole blood clotting test 20 does not exclude envenoming. And then what's the role of FFP in managing WIC? So there's a randomized control trial done in Australia where FFP is given versus compared with the other group did not receive FFP, but both groups received antivenom. So what happens is when you give FFP, the coagulopathy recovers faster, but then still the hospital stay times remain the same in both groups. So recovery is faster, but the hospital staying time was the same. In Sri Lanka, there was an RCT again, but in that trial, they basically compared 20 vials of antivenom versus 10 vial of antivenom plus 4 units of FFP, the outcome was same. So the primary outcome was different to the first one. So they basically, what they showed was that 10 vials of antivenom plus FFP is not inferior to 20 vials of antivenom only. So, but in summary, what we can assume is that in cases where patients continue to bleed after first dose of antivenom, you may use FFP as a trial so that it might accelerate the recovery from that. But then there are certain issues. For example, hump nose vipers, we don't give antivenom. But in hump nose viper coagulopathy, sometimes people might be interested in giving FFP. So what we have observed is every time you give FFP in hump nose viper patients, D-dimer levels go up. That means the venom level, venom toxins in the blood, which are not neutralized by antivenom, will continue to consume whatever the FFP that we give. So it kind of worsens coagulopathy rather than resolving. So FFP could be used in cases where bleeding does not settle with antivenom. The last one, what is the role of therapeutic plasma exchange in managing patients with MAHA or TMA? So there was a recent review which again showed that there's no proven benefit of TPE for snakebite associated TMA, and there are two studies, observational studies, that are showing that the TPE did not have a better outcome, and in fact the patients required more blood transfusion, dialysis, and so on. But there are case reports suggesting both ways, like better outcomes as well as poor outcomes. But whether giving TPE early has a role, that needs to be further explored. One other caution is that TPE might effectively remove antivenom rather than any toxin. So that is the other concern. You might remove antivenom better from the patient rather than a toxin. So that's again a caution. So no current evidence to support TPE in MAHA and AKI or TMA patients, and it might remove antivenom effectively, so we need to be concerned about it. So in summary, snake venom is not a single bioactive substance. They have different PKs and PDs. We don't fully understand pathophysiology, but we understand this narrow window of opportunity to treat these patients. And therefore, antivenom should be given as early as possible rather than trying to give late repeated doses. And negative whole blood clotting test 20 minutes does not exclude envenoming. And you can use FFP in cases where bleeding does not settle with antivenom, but not without antivenom. And there's no current evidence to support TPE in MAHA or TMA patients. So with that, I thank again for Sri Lanka College of Internal Medicine for giving me opportunity to speak in front of you. Thank you.
Thank you very much, Professor Anjan, sharing your expertise. I think a lot of gray areas you cleared. We'll introduce our next speaker. It's my great honor to introduce our next speaker for our symposium today. Professor Indika Gavarammana. He's a senior professor of medicine, Faculty of Medicine, University of Peradeniya, as well as he serves as a consultant physician, Teaching Hospital, Peradeniya. He will be talking about crisis intervention, acute management of psychoactive substance misuse. Over to you, sir.
Good morning, everyone, and thank you very much. Good to be sharing the stage with Anjana. You are, I think, second MPhil student after Kalana, and then he speaks for our success at Peradeniya. So you can see that I work at the University of Peradeniya, Faculty of Medicine, and also I give leadership to South Asian Clinical Toxicology Research Collaboration, which does a lot of research in toxicology in Sri Lanka. We have, I think, produced about 50 postgraduate students, several MPhils and PhDs. And then our biggest success story is that we have been able to save about 150 lives over the evidence that we created, that the government took up our evidence and, acted. And then I also work at Teaching Hospital Peradeniya. I was like a thoroughbred Peradeniya, did my undergraduate, postgraduate, and now I'm working there as well. So now I'll be talking a little bit about the epidemiology of psychoactive drugs. I think it was a pretty hot topic a few weeks back. I think it died down a bit. I'm sure it'll bounce back. Then we'll also talk about how to diagnose recreational drug, classical drug use, and then new psychoactive substance when you are faced with the patient, and of course, a bit about management. Now, it's a big problem. This is a nice study that was done about using patients who present to hospitals in Europe with a drug-related problem. You can see nearly 70%, if you add these numbers, about 70% of all these admissions to drug-related or tablet-related admissions are due to illicit drugs. And if you look at the individual drugs, heroin tops the list with cocaine, cannabis, GHB, which you don't see it here, but I think it is a problem here. It's a liquid like this, clear, colorless liquid, which is used as a date rape drug in the West. You go out to a pub with somebody on a date, and you find that person very interesting, and then a little bit of GHB into this clear, colorless thing. It doesn't alter the taste of your gin, and you initially feel good, and then it has a very narrow therapeutic index window, and then you lose consciousness, and then next morning you find yourself missing all your belongings and then being raped. So. And it's a big problem. This drug trade is a big problem. And I looked for Sri Lanka in this. It's not there actually in this map. There is this golden crescent, the golden triangle, where drugs are manufactured and transported across. I don't know how they missed Sri Lanka in this map. I'm sure when they redraw it in the next few months, I think we will have our place in the world scene. Okay. Now, what about Sri Lanka? There was just one study that was published in Sri Lanka about these drugs, and this was a study done amongst people who go to rehabilitation centers after being treated for drug withdrawal, and of course, cigarettes. Most of these people, they interviewed about 207 people, and a lot of them smoke cigarettes, but then you can see cannabis, about 90% of them use cannabis, heroin, 83%, methamphetamine, ice, about 73%, cocaine, and so you can see that they're using a lot of these things in this country. And we discover lots of them, and people discover little packets of heroin and cocaine in their wallets, and we've done so well. Now we discover them in truckloads and even factories. So we are developing. So why is it such a big problem? If these are figures from Sri Lanka in 2020, the actual worth of confiscated drugs. It's a big business. That's why people take such a lot of risk producing them, transporting them, and becoming very innovative as we go. So into billions. Heroin 42 billion, and you can see this is 2022. ISO is actually a small player, 5 billion. But I think that this must be topping the list now. And if you look at the world drug trade, it amounts to about 1% of the global GDP. That's into billions of dollars. So why I'm worried about this is because deaths due to drugs of abuse, psychiatric drugs, a number of deaths keep increasing over the decades. Though this is not a major problem in this country, but I think it's going to be in the future. So I think as practicing doctors, physicians, registrars in medicines, and other doctors, I think you're going to face this epidemic in the future. So I think you should be ready with it. So psychoactive, what do they do to you? I mean, they can do only one or three things. Either they can stimulate your brain, depress it, or make it go haywire. That's what they can do. And I think in small amounts, they will do it, well, I suppose, okay. But then if you take it too much, then, things go haywire thereafter. So what do the stimulants do? For example, if you take amphetamine, what it does is there are these several receptors, and amphetamine is taken up by this dopamine transporter. And what the transporter does is it takes dopamine back into the presynaptic terminal. But when dopamine gets attached to it, it reverses this process. It reverses where dopamine is released into the synaptic terminal. There's increased release. It does the same thing to noradrenaline, norepinephrine. So you get when you take too much, you get loads of dopamine, loads of norepinephrine in your synaptic terminal. It's like if you take too much, it's like injecting noradrenaline into your system. So they depress, like if you take morphine, for example, it depresses everything, reduces cyclic AMP, and then reduces all the activities, the brain, autonomic nervous system, peripheral nerves, or everything. And hallucinogenics make you go haywire. It stimulates the serotonin receptors and brings about all these the nice feelings that people use it for. Specifically, it stops filtering information. This thalamic filtering system is a system that filters information that goes into your cerebral cortex. That disrupts that then. And then it's also, you lose reality. So if you take hallucinogenic, what it does, it reduces your inhibitions, increases your sensory perception so that you start seeing things, start hearing things, and of course it reduces awareness of reality around you. So now getting back to the subject, this is what I was asked to talk about. So there are three types. Three things that you need to worry about. They present, irrespective of what the patient has taken, they present in three different ways. They can come with effects of stimulants, depressants, and hallucinogens. There are different drugs. I think all these are available in this country, except I'm not sure about GHB, but I think it is also available. Because we hear this newspaper, we see these newspaper articles that describes episodes where, I got into a bus from Colombo to Kandy, and then I met this guy on the bus. He offered me a drink, I drank it, and I don't know what the hell happened thereafter. I lost everything I had. So I think it is available, but we don't have data on it, but we have seen quite a lot of patients who lose consciousness on the way, and they get robbed. So I told you, talking about stimulant toxins, I told you it's like injecting noradrenaline into your body. It causes agitation, aggression, psychosis, sweating. I think that's due to dopamine overactivity, sweating, dilated pupils, seizures, hypertension, you get chest pain because of coronary vasospasm, you get arrhythmias. So those are because of noradrenaline, norad that is going all over the place, and hypothermia because of serotonin overactivity, which can cause hypothermia, rhabdomyolysis, renal failure, DIC, and you can also get either hemorrhagic strokes because of severe, very high blood pressure, or you can get a thrombotic stroke. So these are all, we have seen all these things happening elsewhere. So how do you manage them? Depending on what the predominant symptom is. I mean, you don't remember one thing in managing, you need to diagnose it and treat it. Treatment is, you put them in a very quiet place, dark place, without any intervention. Don't go and ask them, where did you take it? How much was it? This person, that person, did you buy it from that place in Mathura, things like that, Do you know the underworld? You don't ask those. Could you put him in a dark room, very reassuring aspect, and then give some loads of benzodiazepines. That's what it is. Another serious issue is hypertension. Blood pressures can be very high with tachycardia. The treatment of choice, along with benzodiazepines, is nitrates, giving nitrates. That's a bad drug, but you must make sure that you avoid beta blockers because if you give beta blockers to someone who has got lots of noradrenaline, but and then of course the NORAD will act on your alpha receptors. There are alpha receptors unopposed, and then you get a catastrophic hypertension and all the complications of a catastrophic hypertension. So you have to, GTN is the best drug. If you're giving it, you want to combine it with an alpha blocker. The second problem with stimulant overdose or stimulant toxicity is hyperpyrexia. This is because of overactive of the serotonin system, and you need to cool them very rapidly. Otherwise, they can develop rhabdomyolysis, acute renal failure, and DIC. And there are multiple ways of cooling them. You can pack them in ice, which does a very good job, very rapidly cools them. You can spray them with water, and then you can give cool saline. Again, if you're very bad, then you have to paralyze them and ventilate them. Benzodiazepines are very good again here. If hypothermia is a serious problem, then you can use cyproheptadine, which is a serotonin antagonist, large doses through an NG tube until the temperature comes down. You must make sure if you're ventilating them to avoid fentanyl, because it also has serotonergic effects and you can make it worse. So make sure that you don't use fentanyl. So this is about another patient. Tourist coming to ED with found unconscious with low GCS, small pupils, bradycardic, hypotensive, and low saturation. So this obviously, any thoughts from the audience? If this was a farmer, you might say it's organophosphorus. Anjana would say it's organophosphorine 6 diet. But this looks like an opioid overdose. So it's a depressant. It does depress everything, GCS, blood pressure, pulse rate. So it's easy to identify this syndrome. It's the opposite of what you saw before, really rather quiet, calm, and barely breathing person. So this is, it's easy to remember. If you're looking at the opioid overdose, this is the opioid toxidrome. CPR 3H, coma, pinpoint pupils, respiratory depression. Then 3H is hypotension, hypothermia, and hyporeflexia. That will give you the diagnosis of opioid overdose. And benzodiazepine overdose also is somewhat similar, but their pupils are not pinpoint. They're like a mid-sized pupils, but everything else is about the same. So, I mean, I don't know how good it is, how good a size of the pupil is, but if it is definitely, if it is pinpoint, it has to be an opioid rather than a benzodiazepine overdose. And of course, you should remember how to manage. I mean, if you have a patient, this patient should have been given an naloxone on the clinical diagnosis. Do a dose of naloxone to reverse its effects. It acts pretty quickly. You can go up to a 400 microgram doses, between 100 to 400. Repeat every 3 to 4 minutes until the patient is, about like a medical student type of GCS, barely awake. Don't give too much, because they'll start. Their GCS will increase to about 20 and they'll start running away. So just about that level. And sometimes they need infusions, long-term infusions. You give about 2/3 of the initial dose that was adequate to bring the patient to a decent level of GCS. So you have to maintain that infusion over every hour. So this patient, of course, was given 2 milligrams of naloxone, but he didn't recover. Then you need to put your thinking hat on, see, okay, am I missing something? If it was opioid, this patient should have woken up by now, but not so. Then you need to think of other causes, alcohol, benzodiazepines, GABA overdose, new recreational drugs, and of course, medical causes. I think this is where you should get your knee and do a plantar reflex. If the plantar is going up, it might be a medical cause. Now, this case was, of course, a GHB overdose, but at that point, you will wonder, do I need an investigation to work out what the cause is? Like there's a urinary drug screen. And, don't waste your time. You're not going to get much out of it at all. They have been proven to be not very useful. Your clinical diagnosis is more than enough to make the diagnosis. We're coming to new hallucinogenics, and, it gives different, as I mentioned before, gives auditory hallucinations, visual hallucinations, euphoria, sensory distortion, various things. Because of the serotonin effects, you can also get hypothermia, tachycardia, sometimes hypertension, and all that. So management is like basically supportive care, put them in a cool, calm place. Fluids, they can be hypoglycemic, make sure that you correct that. Symptomatic management is basically at benzodiazepine. So you need to remember basic two drugs now, benzodiazepine and naloxone, yes. And fluid replacement, you need to monitor them. Some of them have a long half-life, so you need to look after them for a longer period. And of course, you need to get them counseled and, give them advice upon discharge. So there's a little bit about, so those are the classical psychoactive substances, but there are newer psychoactive substances. What they really do is they change a little molecule here and there, change the structure here and there, and then that'll give you a newer product with newer effects. And more importantly, these will not be diagnosed by routine drug screening by the police. They fail to detect this. That is why they keep changing this molecule every time. So every year you get new things coming. So, well, if you want to get into business, this is a rapidly evolving place. There's a lot of money around. So there are several classes of these newer psychoactive substances, cannabinoids, benzodiazepines, and now opioids. And it keeps evolving very rapidly. Get a lot of new products coming every year. Quite a lot of them coming every year. And then you can imagine the demand. So they are produced in different parts of the world. And now I think we should proudly put our map here. We've also produced these things. And this is just to tell you how the things evolve. This is how the cannabinoid structure evolved over the years. They are very innovative. They keep changing the structure to evade drug detection at customs. And they're packed into some powders, some powder. They are exported as powders for various users. And they fail to be detected by the drug authorities. So we have two types of psychoactive substances, classical ones, stimulants, depressants, hallucinogens. Psychoactive substance, again, same stimulants, depressants, and hallucinogens. They act the same way, and their management is the same. So you need not worry as to what the patient has taken. Don't worry about the drug. You look at the syndrome, identify the syndrome, and treat the syndrome. Work out whether it's a stimulant, depressant, or a hallucinogen. Treat the patient. Don't worry about the names. See what the patient looks like, and then treat it. And again, the last slide is you need benzodiazepines, cooling, nitrates, and fluids for stimulants. For depressant, you need to manage the airway, sometimes give oxygen, naloxone, and supportive care. And for hallucinogens, calm, quiet environment, benzodiazepines. If they're hallucinating too much, you can give some haloperidol, and then supportive care. Thank you.
Professor Indika Varaman, thank you for that excellent lecture. We ask you to come to the podium. Our next lecturer is Kapila Marambage, and he's going to talk to us. He's an associate professor in the University of Texas, Southwestern Dallas, Texas. He's going to talk to us integrating addiction management to the medical practice.
Hi, good morning, everybody. Thank you for being present, and thank you for inviting me for this to this conference. I especially want to thank Dr. Krishantha Jayasekara, who was my colleague at the Faculty of Medicine, Colombo, many years back, and it's a privilege to be addressing a Sri Lankan audience. And one of the main concerns that I had was that I don't have any clinical experience managing addiction disorders in Sri Lanka. But Professor Gauramana actually relieved me of that distress because he presented a lot of clinical experience. So that's quite a relief. And also he presented a lot of statistics, which I'm also going to refer to, because part of the research that went into this talk came out of the pattern of substance use disorders in residential facility, which you quoted from Dr. Jayamaha and others, and the drug use patterns in Sri Lanka, substance use disorders in inmates, which was done by Dr. Hapangama in 2021, and the prevalence of substance use disorders in a tertiary care hospital in 2021 also, which was done by Dr. Suravira and others. So I'll move into my presentation. I am an associate professor, as I was told, as I was introduced, at the University of Texas at Southwestern, and I work at the Parkland Hospital in Dallas, Texas, and I'm the medical director for the addiction psychiatry services through the UT Southwestern system, and especially at Parkland. And the talk involves substance use in Sri Lanka, which I'm not going to elaborate too much because Professor Gauramana pretty much he covered it all. And then I will go into medication-assisted treatment models in the United States, which we practice, and try to give the rationale and the possible benefits of that. And I also will try to present on a treatment model which we specially practice in the United States, which is an addiction psychiatry service, like a consultation liaison service, which operates at Parkland, of which I am the medical director, and done by the UT Southwestern. And that includes consultation liaison, addiction psychiatry services, hub and spoke model, where we coordinate care through a main campus in the Parkland Hospital and then branch out into our clinical network. Screening and brief intervention and referral to treatment models, and to see whether that might be a compatible model to go beyond the detox in Sri Lanka. So some of the statistics, which I'm not going to take a long time talking about because Professor Gauramana already discussed. The most commonly used substances in Sri Lanka, cannabis, followed by heroin, and then methamphetamine and cocaine. And it's quite high prevalence in that sample that they looked at. Heroin is a significantly problematic substance, it looks like. Sri Lanka is a transshipment hub for heroin trafficking from India. So therefore, it becomes like quite a significant problem, I think, in Sri Lanka. Good thing about the heroin use as compared to the United States, in Sri Lanka, what I noticed was that Sri Lankans do not use IV heroin as much as in the United States. In the United States, it's quite a lot of intravenous heroin use, which causes a multiple set of problems, including overdoses. And I'm sure the foreigner who had the overdose in your situation might have probably used IV. So likewise, in the United States, the overdose risk is pretty high with IV. And there are other problems like HIV, which you don't see as much in Sri Lanka, because in Sri Lanka, mostly what they do is something called chasing the dragon, which is evaporating the heroin in a way that it develops into a fume, and then you smoke it through like a straw and inhale or smoke it through a straw, which is called chasing the dragon. As compared to the IV drug use, it's a little safer than that, safer than the IV use. The typical person is an unmarried Sinhala Buddhist young adult, males, low education, employment and instability seen, some aggressive behavior during childhood is a common finding, 18 years plus or minus 5 years. Peer pressure is quite a factor. About 1/3 of the people have had childhood bad experiences, family issues, neglect, strict parenting, loss of family members as such. And then social factors when we consider, quite a big situation is peer pressure, which has been cited. And also, most of the patients or the people who were researched had quite a bit of prevalence of substances in their neighborhoods. There is ex-combatants and unemployed individuals who are at the risk of drug use. Criminal activity, when you consider, there was a study which I have quoted out of the prison population, 45% of the prison inmates were incarcerated for drug-related offenses, including property crimes, burglaries, as such. And then 160,000 arrests during 2023. Colombo district was the highest, followed by Gampaha district. And legal consequences, about 20% due to drug smuggling and possession. More than 50% drug offenders were repeat offenders. And if you consider the murder and attempted murder convicts, a large percentage, like about 80%, had met criteria for substance use disorders. Some more statistics. So low HIV prevalence in Sri Lanka as compared to United States. In the United States, we have HIV, hepatitis C as quite a significant issue when it relates to IV drug use. And then in certain parts of the country, like where I practice, which is the southern United States in the Texas, which is closer to Mexico, the kind of heroin that we get is a little different than the white powdered heroin that is more prevalent in Sri Lanka, which is called the black tar heroin. And when it comes to the black tar heroin, it is contaminated quite a bit with anaerobic organisms, Clostridium organisms. So what happens is it leads up to venous sclerosis, like as if a patient is going through chemotherapy or something, and they lose venous access, and then they start injecting their soft tissues, which causes necrotizing fasciitis and abscess formation and issues of that nature, which causes long-term infectious disease. Whereas you're lucky in Sri Lanka, so far the HIV rate has been low. And so apparently there were a high percentage of suicidal ideation and also attempted suicide. Some people will seek treatment in Sri Lanka. Heroin is the predominant substance that people will seek treatment for in Sri Lanka. In the prison study, they also found a high prevalence of dual diagnosis, which means that you have substance use disorder and also a concurrent diagnosis of a psychiatric disorder like depression, anxiety disorders, schizophrenia, bipolar, so on, so forth. And significant association with past medical illness and likelihood of a substance use disorder, which we consider sometimes in the United States as a self-medication strategy. Dr. Gauramana explained about the different uppers and the downers and the hallucinogens. Sometimes when people are down with psychiatric illness, especially mood disorders and anxiety disorders, they might resort to using drugs as a form of self-medication. So you will have substance use disorder following mental illness. So common motivations are like for stress relief and anxiety relief. So those are some of the statistics that I got from Sri Lanka. And so going into, I didn't elaborate, didn't focus on alcohol and tobacco too much. Well, I know you all are medical professionals, you know quite a bit about this, but I will say that in tobacco use, in pregnant women, what we have found is that it can induce intrauterine growth retardation, premature birth, smoking-induced hyperalgesia. There was a very good talk on the day of inauguration about diabetes and the prevalence of diabetes, and that it's going to be a big problem in Sri Lanka. So smoking has had some connections to hyperglycemia, hyperinsulinemia, and endothelial dysfunction, which causes a risk factor for diabetes type 2. And also cardiovascular risk. Secondhand smoke can cause type 2 diabetes and obesity. There are some links there. Alcohol, I don't want to go into too much, but when it relates to diabetes, heavy drinking can lead to impaired glucose signaling, beta cell dysfunction, insulin resistance, which can, and then also gluconeogenesis, we all know how that impacts, and hypoglycemic episodes as a result of that, which can be a connection to diabetes. Binge drinking also relates to type 2 diabetes, precipitates DKA. Cocaine in the prenatal use can cause low birth weight metabolic syndromes as such. And metabolic syndrome in turn can cause increased psychiatric comorbidity. And then the psychiatric comorbidity leads to psychiatric medications, which in turn feeds into the metabolic syndrome. And then when you have a metabolic syndrome, the apathy that comes with that, and also psychiatric comorbidity, that leads to self-medication with drugs, which leads to a comorbid substance use disorder. A little bit about the methamphetamines, because that's a prevalent problem, as Dr. Gauramana was talking about, how that impacts. In the United States, the common consult that I get in the hospital for methamphetamine is when they are down with a cardiomyopathy. And these are the mechanisms that causes cardiomyopathy due to methamphetamine use. I'm sure you will run into this in the near future. And how it does is that it does in two different mechanisms. It does direct cell toxicity on the cardiac muscle. It causes mitochondrial dysfunction, calcium signaling issues, which causes contractile dysfunction and leads to fibrosis. So that's one system. Second thing is that methamphetamine, like Dr. Gauramana was saying, is a stimulant, and it causes sympathetic activation, causes vasospasms, hypertension, tachycardia, which leads to ischemic incidents, myocardial wall stress, which causes acute cardiomyopathy, which in turn with repeated exposure can lead to chronic cardiomyopathy, and coupled with the fibrosis, you end up with a patient who has chronic cardiomyopathy. And what we see in the United States is that when they have chronic cardiomyopathy, they have difficulty kind of getting out of bed because they're short of breath, they're apathy, they're listless. So the treatment that they know to lift themselves up is to go back to the methamphetamine, which makes it even worse. So it's like a vicious cycle in that sense. I want to talk, those are the medical issues that we confront due to the drug use, which I'm sure you will, if it's not prevalent yet, it'll come into fusion pretty soon. And Dr. Gauramana elaborated on a few cases of opioid issues. We have a lot of issues related to opioids, including the overdose problems and also the infectious disease issue that I was dealing with, which I was talking about earlier. So, importance of integrating substance use disorder into a medical practice is the next slide that I have here. So, now in the United States, my effort in the Parkland Hospital and through the University of Texas is to integrate as much substance use disorder treatment into the general medical practice. So how I function, which I will go into in a little while as a consultation team, is to generate consults from the medicine folks, internal medicine, family medicine, the hospitalist services, surgical teams, OBGYN. They generate consults to us whenever a patient is admitted with a medical issue and they have a concurrent substance use disorder, they will consult us. So we concurrently manage the substance use disorder while the medical folks are handling the medical issue. And it helps in reducing the disease progression. It takes out, the treating substance use disorder, which stabilizes and improves the chronic diseases like managing alcohol-induced blood pressure issues and all that, and our diabetes. Better adherence to medical treatment. As you might know, when people are into drug use, they have nothing else is important. So they will neglect their medical illness, which leads to chronic problems. Like if you have hypertension, you're doing alcohol or another drug which perpetuates that problem, it leads to more complications due to hypertension, and it's a big medical issue later, which impacts the healthcare system and the costs. Lower complication rates, which is malnutrition, infections, all that comes with the substance use disorders. Example, IV drug use, needle sharing can cause HIV, which can add to a lot of health costs. And also, integrating the substance use disorder treatment into a general medical practice can also take out the stigmatizing effect and also normalizes addiction as a treatable disease. And also, we have an ethical responsibility to consider our patients as a whole, that substance use disorder is part of their problems, and try to treat it alongside other medical illnesses. And so alcohol use disorder, of course, you all know how to detox the patients with benzodiazepines and other ancillary medications which we use, I'm not going to go into. But beyond that, we use all these different medications in order to keep them away from alcohol. Main medication that of research is naltrexone, which we give if the liver function is fine. If they they are not on any opioid medication, then we try to use naltrexone because it's a opioid antagonist, and therefore we have to make sure that the liver function is like upper limit of LFTs are within normal range. And then we start at 25 milligrams and increase to 50 to 100. That is a maintenance dose. It has quite a good success. A compressate is another medication which balances the GABA and the glutamate dysfunction which happens in alcohol use disorder, which I'm not going to elaborate into, but the imbalance that alcohol creates in the GABA and the glutamate system will be rebalanced through a compressate. Same thing happens with topiramate. Gabapentin is also a good ancillary medication which treats patients' protracted alcohol withdrawal and also keep them away from going back to drinking. Disulfiram, which is anti-abuse, and if you take it, then you cannot be drinking because you will start having a negative reaction to alcohol. And then I'll go to the other opioid medications that we use, the maintenance medication. Methadone, buprenorphine are the mainstay, and I'm not quite sure whether buprenorphine is available here or not. Anyway, if it is available, it's great. Otherwise, the third one is the naltrexone. So methadone is a full agonist opiate on the opiate receptor. Buprenorphine is a partial agonist antagonist at the mu receptor. And naltrexone is a antagonist. So I will not elaborate too much. We have a fentanyl issue in the United States, a big fentanyl issue, which is a very powerful opioid. It has a very high mortality rate when used. And sometimes it is used to adulterate the stimulants, because when people do stimulants, they become really psychotic in the United States due to the synthetic stimulants. So they will incorporate fentanyl so that this high is not like over the top. so that the fentanyl will keep them a little kind of, so it's an upper and a downer combination. But those people who are opiate naive will get overdosed on the fentanyl. So when a person is fentanyl positive, of our hospital database, we have about 80% positive for fentanyl. The induction methods are different, and I'm not going to elaborate too much into it. We give some antiemetic medication, and then we start on a low dose of buprenorphine and then escalate the doses. Basically, the protocols depend on whether the patient is fentanyl positive or not, because fentanyl, although it's a short-acting opiate, it stays long in the body due to being deposited in the fatty tissue. So it can keep coming back and causing a withdrawal. And because buprenorphine is a partial agonist-antagonist, it causes something called precipitated withdrawals, which is way worse than a normal withdrawal. And we want to prevent that. So this is a protocol for that, which I'm not going to elaborate too much, but it depends on whether the patient is positive for fentanyl or not. And then in case of methadone, we don't worry too much because it's a full agonist. It doesn't interact with the fentanyl in a negative way unless the patient is already intoxicated. So we will wait for the patient to go into withdrawal, make sure we do ECG or EKG as we call it in the United States, watch for the QTC interval, and if it is not too prolonged, then we start methadone. We generally tend to keep them around 40 milligrams or less when during the induction, and then we will refer them to a methadone clinic outside. So basically the scale that we use is called the COW scale to evaluate the opioid withdrawal syndrome. And then based on that, we will give methadone and then refer them to a methadone clinic. So stimulants-induced psychosis, I think Dr. Gaurammana also talked about it. The mainstay, as he said, was a benzodiazepine, which is called clonazepam. In moderate and in severe, we use Valium, IM, or IV. And then a combination of benzodiazepines. Sometimes we have to use an antipsychotic. Of course, if it's hypothermia or anything like rhabdomyolysis is involved, then the management is a little different, if cooling processes are used. Otherwise, IV valproic acid is also a useful medication during intoxication. Sometimes we use a little bit of Haldol or Zyprexa, which is our risperidone, in order to manage their psychosis, especially when they come out with PCP also, which they become really aggressive. So that's the moderate and severe management of stimulant-induced agitation and psychosis. Then when it comes to methamphetamine and cocaine, we have a few medications that we use as deterrent medications. When you use the word deterrent, that means that they will hopefully not go back to the drug, or the cravings will drop to a certain degree. For the methamphetamine, which is going to be a problem in the near future, most likely in Sri Lanka also, we use the combination of bupropion and naltrexone with some efficacy. I wouldn't say it's super good, but in about 20 to 30% people, it helps, especially if they have combined stimulant use with alcohol or smoking. Smoking cessation also, Wellbutrin or the bupropion is helpful. So we to take that combination. There is little evidence to support Topamax, which is topiramate, and also mirtazapine, and also paliperidone. And Abilify has gone out of fashion now. But disulfiram also might have some use in the case of methamphetamine, but I wouldn't go with those. Anything below Topamax, mirtazapine also can help. Anything below that we don't use too much, but bupropion and the naltrexone combination might be something that you might want to consider if you want to use for a methamphetamine user, because bupropion is also dopamine agonist and it kind of uses that pathway, not like methamphetamine, but it helps. In the case of cocaine, now, also for methamphetamine, there is a subset of population in the United States who have had this condition called ADHD or ADD, and they are self-treating themselves with methamphetamine or cocaine because their ADD medication has been stopped by their child, whoever the psychiatrist. Now they are adults and they cannot focus. So for the focus, they might use cocaine or methamphetamine, especially cocaine. Methamphetamine makes you a little crazy, so they will not do that, but they will do cocaine, which is kind of, they will keep them focused and attend to that stuff. So for that, we use Adderall and Vyvanse and a combination. So I will go through the next slides rather quick because my time is up. we do motivational interviewing, CBT, contingency management, dialectical behavioral therapy as modes of treatment. And we do screening methods, including asking a few questions, the slides of which you will have available to you. 3 questions to ask to screen and then go to the next level. This is my team that I work with at the Parkland Hospital. And I have a combination of doctors and nurse practitioners, psychologists, social workers, and even a peer navigator. Peer navigator is somebody who is recovered from drug use and been sober for about 15 plus years. So when they go to a patient's room and talk to the patient, it's better than a doctor going and talking to them because it's one of their colleagues, who have gone through recovery. So this is my team, and I'm not going to elaborate too much on the stuff, but the numbers are the same. We deal with a lot of alcohol, a lot of stimulants, a lot of opiates. And then we make a referral system. And I'm not going to go through these slides too much also. Basically, we manage the withdrawals, but we go beyond withdrawals, starting deterrent medications and referring them to treatment so that they can continue treatment. And then in terms of the treatment, we have something called the hub and spoke model. Hub is us, like our main clinic where we have the expertise, and the spokes are like peripheral clinics which we communicate through electronic medical record system, which we have an e-consult system, so they can generate a consult. They will ask us questions how to manage a certain patient, and then we respond to them electronically. So that's a hub and spoke model. And these are my references, including the Sri Lankan studies that I quoted. And I want to thank you for listening through, and thank you for inviting me for this symposium. Thank you very much.
Thank you, Kapula Marambagi, for that excellent lecture. I think we have 5 minutes, and we can get 1 or 2 questions from the audience.
I ask a question from Professor Gavaramana. Now, have you come across cocaine abusers? Cocaine is mixed with levimazole. It's an antihelminthic. It causes a lot of other problems, ANCA positivity, neurological problems, and this levimazole used to enhance the action of cocaine. And it is cheap and not illegal. It's used in the veterinary. Have you come across? I have come across a patient.
No, I haven't. Maybe you have. Have you, adulterations happen quite commonly. I mean, they try everything. They need a high all the time. They need to, humans are never happy with what they have. They need to experiment with. So they keep on adding various things. But I haven't actually seen. I haven't managed a patient with cocaine overdose in Sri Lanka. I haven't seen one, actually, to be true. Is it? Okay.
Levimazole, I have heard about it, but in the United States, we don't have that much antihelminthic drugs available. But then, like Professor Gauramana said, they put in a lot of different stuff, some of which we don't even know, even industrial chemicals into cocaine and methamphetamine to enhance the effects. And so many, like they will make a change, and then when Sudafed is taken out of the counter, they have started using all these industrial chemicals and stuff like that to enhance the effects. It is prevalent, but I wouldn't know whether there's a difference in the management if you get a patient.
Actually, these days I'm working in the prison hospital. Because of that, we see a lot of patients with addiction, especially these amphetamine patients. They come with the cardiomyopathy at younger age. Is there any specific treatment that you have come across, or any specific management for that kind of cardiomyopathy?
For the cardiomyopathy itself, what happens in the United States is that they will administer the cardiomyopathy treatment, including sometimes even putting defibrillators or any interventional methods, but they would not want to move forward because the kind of wait list is a bit, and they will not give high priority to the substance users because their thinking is, what is the point in doing an intervention if you are continuing to use drugs? So they first want for us to manage the drug use, for which we use mostly intramuscular naltrexone, which is called Vivitrol, plus the Wellbutrin in combination for them. In some cases, if I detect that they have ADHD, which they are self-treating with the drug use, I might even go for stimulant medications like Adderall or something like that, so that their main issue is solved, and hopefully they will stay away from drugs. And then we'll do contingency management where we reward them for urine drug screen negative, so that, and then show the internal medicine or the cardiology folks that they are staying in line and they get their interventions through them.
Other problem?
Actually, you're quite correct. Most of the cocaine in the West is contaminated or adulterated with lamivudine, almost 70%, because it potentiates catecholamine effect. So that's what we haven't seen here. And cutaneous vasculitis separately. Yes.
Congratulations for all three speakers for wonderful talks. Anjana, now this coming into Viper Bites. So the patient on admission, the INR is 4 or 5. What is the best way forward? Are we still to give antivenom and FFP or both?
So what we observed is that now on admission INR 4 patient means definitely INR above 1.5 is considered in snake envenoming coagulopathy. That's how it has been defined. So it's a clear indication of antivenom. So what we observed is the maximum amount of venom injected or detected in the blood of patients can be neutralized somewhere around like 11 to 12 vials of Indian antivenom. So starting dose of 20 is usually enough to neutralize all the venom. But given that, as I said, there's a tricky situation, that is, now there may be patients, because there's a vascular damage also occurring, there may be patients with mild coagulopathy like INR 2.5 or 2, but still bleeding. So again, if there's a patient having bleeding even after the first dose of antivenom, it's always advisable to go with a repeat 10 vials. That's the current recommendation. And also if it is not settling, trying with FFP. So giving FFP after the antivenom is the crucial thing, because otherwise that FFP will be consumed.
Again, thank you all. So with that, we are coming to the conclusion of this interesting symposium. May I invite Dr. Ravi Jayawardena to show appreciation with a token of certificate. First, Professor Anjana Silva. Professor Indika Gavaramana. Kapila Marambage. Thank you all.